Now we will turn to a different topic, medical management and therapeutic drug monitoring. In IBD, um, same information about me. Okay, so we're going to first start with the modern goals of IBD management. So first and foremost is an early and accurate diagnosis. And really important to that is clarification of the phenotype. So where is the disease located? How severe is it? And is it stricturing? Is it penetrating and fistulizing? Does it include perianal disease? Um, and what extra intestinal manifestations are there? Are there peripheral joint pains? Are there central joint pains? Is there uveitis or iritis? Is there psoriasis? And when we take all that into account, we can really determine the prognosis. Is this because the disease activity right now might be different than the overall disease severity, which we take into account by how much of the intestine is involved and how the disease is acting. So we really need to understand what the diagnosis is, where it is, how it's acting before we can really make a good decision about what the best treatment course is. Then, once we've determined that, we need to, of course, induce remission. We need to turn off the inflammation. We need to get the patient feeling well and symptom free. And then we ultimately want to see normalization of their labs, of their growth curve, of their development, of their nutritional parameters. And then we need to keep them well. They need to have stable disease control. We need to make sure their medical therapy is optimized. We need to make sure that they stay well. A lot of times patients will say, oh, I'm well. Does that mean I can stop my medicine? And I say, no, that means you can't stop your medicine, that your medicine is working. And we need to keep doing it to keep you well. And then we need to do disease monitoring prevention. We want to make sure that if there is going to be a flare of disease activity, that we're monitoring for it and we're catching it before it becomes severe, before it becomes really clinically relevant. We want to monitor the therapies. We want to make sure the drug level is what they need still, and that it doesn't need to be adjusted. We want to make sure we're preventing infections, that we're up to date on vaccines and other preventable health care. We want to make sure we're up to date on cancer surveillance. And we also want to consider the long-term consequences of chronic inflammation. So the job isn't done, when we've made the diagnosis and started on a treatment. And I try to set that expectation for patients from the beginning too, that this is, we're going to do these tests to figure out what's going on. Then we're going to meet and talk about a therapy. And then once we start that therapy, this is our goal. We want you to feel good. And then we're going to be checking labs to make sure everything's normalized. And then we're monitoring you. And then we're going to do another scope or another scan or another stool test to make sure that the inflammation has healed, just so that they know they can't just go off the grid once they're feeling well and never see me again. And so what are the things that can really tell us how severe disease is? So the patients with ulcerative colitis that are low risk for colectomy are the ones that have limited extent, or proctitis or proctosigmoiditis, the patients that have mild endoscopic disease activity. The ones that are higher risk for colectomy are those that have extensive colitis, that have deep ulcers, that are diagnosed in an early age, that have really high inflammatory markers, that are requiring steroids or hospitalization, and then that also have opportunistic infections like C. diff or CMV. These are markers for a sick, vulnerable colon that any of these opportunistic things can take over. For Crohn's disease, the patients that are lower risk are those who are over 30 when they're diagnosed, who again have more limited involvement. Of course, the patient that is 5 centimeters of terminal ileal disease is going to be different than the one that has a long segment of ileal and colonic disease. No perianal or severe rectal disease, his more superficial ulcers that's never had a surgery and hasn't had a complication like a stricture or a penetrating complication. The higher risk patients, conversely, are younger, have more extensive disease, have perianal disease, have deep ulcers, have had needed surgery, and have had a complication. The other things to take into account are other immune conditions, so spondyloarthropathy, so other joint conditions, skin manifestations, PSC. We know that PSC carries with it a higher risk colorectal cancer, that we need to survey those patients yearly from the time of diagnosis. Mental health disorders, we know that rates of anxiety and depression are very high in inflammatory bowel disease patients and really affect their care and their ability to be well. Disability, and then the cumulative burden of inflammation. So we really need to take all of these things into account when we are thinking about when to start treatment and what treatment to start and what to monitor them. We can't just sort of look at what their symptoms are at this moment in a vacuum. We need to think about all of this bigger picture items. So I think it's helpful to think about, why do we even use these medications in IBD? We've all seen some sort of permutation of this graphic, that why does IBD happen, right? And this is what I go through with patients too, that are newer to IBD and are just trying to understand why we use the medicines we do. We know that there's some genetic risk. There's over 200 genes that increase your risk of getting IBD, but you can have one of these risk genes and never go on to get IBD. So we can't genetically test, all your kids to know if they're going to get IBD. We think that there's environmental triggers to IBD. We know that there's been a rapid rise in disease in the last 50 years, and a lot of things have changed during that time. Our antibiotic use has changed, our diets have changed, the chemicals in the environment we live in change. And all those things in turn change the intestinal microbiome. We know that IBD patients have altered intestinal microbiome. So there's some combination of a patient that has some sort of abnormal immune response and has something happen inside their intestine to ultimately turn on the immune system, right? Some switch is being flipped on the immune system to do something it shouldn't do, attack the intestine. And the problem is, our current medicines are affecting the last step of that complex process, right? A whole bunch of things happened to that patient to result in their immune system being overactive. And our medicines are turning down that overactive immune response. It'd be a million times better if we understood all those events that led to the immune response so that we could take them away and cure the disease. But since we can't, we only know how to put the brakes on the immune system. So we know how to maintain remission, but we don't know how to cure. And that's why it's so important to stay on a medicine to keep those brakes on the immune system so it doesn't cause damage. So for ulcerative colitis, thankfully, I'm always having to change the slide because we've really had a boon in new medical therapies. For induction of mild ulcerative colitis, we use 5-aminosalicylic acid. That you can see that that's both an induction and maintenance. But remember, that is really for mild, moderate disease. If there's a patient who's really severe, is severe inflammation on their scope, their labs look terrible, their symptoms are terrible, mesalamine is not going to be the right medicine for them. You don't start every patient with ulcerative colitis on mesalamine. There are some that need to start over here at the moderate to severe medications. They don't all need to step through mesalamine. Only the ones that it's appropriate and could actually work for, the mild to moderates, should be put on it. Steroids can be used for induction of remission, so that can be budesonide, and brand name for ulcerative colitis is Uceris, because they do differ in their release, budesonide colon release. Prednisone or hydrocortisone, azathioprine or 6-MP can be used for maintenance, but they can't be used for induction because they're too slow to work. Moderate disease, some patients that are more on the moderate spectrum of mild to moderate can get away with 5-aminosalicylic acid. Biologics and novel small molecules, so the S1P receptor modulators or JAK inhibitors. And then for severe disease, we'll sometimes use cyclosporin or tacrolimus for induction. But we're going to get more into the details of these in coming slides. Crohn's disease, it's similar, but mesalamine is not approved for Crohn's disease. Crohn's disease tends to be a disease where the inflammation really goes beyond the mucosa and is deeper than 5-aminosalicylic acid can really penetrate. So it's really not an effective therapy, and it's not FDA approved for Crohn's. So there'd be very few circumstances, perhaps the patient with real mild, aphthous ulcers sprinkled in the colon, maybe. But it's really not an approved therapy for Crohn's. So that's one of the big differences, but otherwise, most of the medication classes are in common. So how do we choose? We have so many medicines now. How do we make the decision? So you want to know where the inflammation is, because you want to make sure it's targeted to the right spot, right? If it's in the rectum, putting a medicine right on the rectum with a suppository or enema makes a whole lot of sense. How severe is the inflammation? Like I was just mentioning, if it's severe ulcerative colitis, mesalamine is not the right first medicine. If it is mild disease, maybe a biologic is not the right first medicine. So we really need to think about that disease severity. Does the patient have other inflammatory diseases? Do they have joint pains and they need a biologic that's good at treating inflammatory arthritis? Do they have psoriasis and they need one that can treat psoriasis too? Because then you're really going to want to choose something that can treat both conditions. Does this patient have particular safety concerns? Do they have cardiovascular disease? Do they have a prior clot? Have they had a prior cancer that we need to take into account? Are they on other immunosuppression or other medications for other conditions that they have that we need to think about? Is a patient willing to take the medicine? There are those patients that are like, I can never give myself a shot. I know that. I know, I'm going to be too scared and too nervous. I'm going to avoid it. Well, then it's not going to work if they can't take it. Or there's patients that are like, I can't go in for infusions. I travel every week. It's not going to work for me. I can't make the appointments. And so it's really a shared decision between you and the patient, because you need something that's going to work for them and they're going to be willing and able to take. And then finally, unfortunately, the world we live in is the medicine too expensive. If they can't afford it, if this is going to cost them thousands of dollars, that's not going to be a viable option. So unfortunately, we need to think about, how are they going to actually get the medicine concretely? Can they pay for it? Are there programs we can enroll them in to help them pay for it? There are, if we can connect them with those resources, but we have to make sure it's feasible for them to actually get the medicine. So, optimizing response. We know that in Crohn's patients with shorter disease duration, they respond better, they lose response less often, they have less surgery. You really want to use the right medicine at the right time. You don't want to have patients sort of have to earn the most effective therapy for them, because you're allowing damage to accumulate. This is a slide that's in most Crohn's presentations. And what it shows us is, the disease activity has these flares and these periods of remission where you have more symptoms, you feel fine, more symptoms, you feel fine, more symptoms, you feel okay. But during that whole time, what's happening is that damage is accumulating. So over time, inflammation becomes scar tissue, inflammation becomes a scarred stricture, or inflammation penetrates through the bowel wall and causes a fistula or abscess. We have anti-inflammatory medications, but unfortunately, we don't have any anti-scar tissue or fibrosis medications. So we don't want to get to that point where our medicines can no longer be effective. We want to use them early when they're going to make the most impact. So we want to make the decision, what's this disease severity? Do they need this medicine? If so, let's give it to them now. Let's not wait and see if they fail this or fail that and have accumulated damage before we give them what they actually need. Okay, now we're going to get through a little bit more of the nitty gritty of the medicine particulars. So azathioprine, 6-MP, methotrexate. These are older medications. They are immunosuppressants. Azathioprine, brand name Imuran, or 6-MP, brand name mercaptopurine or pyranethol. Those medications are really working. They're called thiopurines collectively. They're really working at the bone marrow level. They're just kind of turning down that whole bone marrow so less white blood cells are made. With that comes more risk. We know that there's an increased risk of non-Hodgkin's lymphoma and non-melanoma skin cancers like basal cell or squamous cell skin cancer, because they're less targeted. They're slow acting, so they're not going to help in a flare. They can be used either as steroid sparing agents. When I was first in training 15 years ago, we put patients on steroids and then we put them on azathioprine or 6-MP to maintain the remission that a steroid got them into. But we don't use it for that as much anymore, since we have safer, more targeted options. Oftentimes, we're using azathioprine or 6-MP in combination with an anti-TNF. Combination therapy has only really been studied in the setting of anti-TNF plus azathioprine or 6-MP. We know that that combination helps boost the anti-TNF drug level and helps prevent anti-drug antibodies. There was one publication that had small patient numbers, but suggested that we can target a lower dose range for the azathioprine or 6-MP if we're using it in combination. But you need to monitor these patients carefully. They need blood tests at least every 12 weeks to make sure that their liver tests are normal and that their blood counts are normal, that their white blood cell count is not overly suppressed. So they really need to be adherent to monitoring. In our practice, we do that through only giving them a 3-month supply. They cannot get a year supply, because that way, when we get the refill request, we're like, oh, did you get your labs? Like, well, you can't continue to be on the medicine unless you're getting the right monitoring. They need to see a dermatologist for skin survey and skin monitoring because of that increased risk of skin cancers. Methotrexate on its own is only helpful in Crohn's. It has been studied in ulcerative colitis, and it does not work as a therapy on its own for ulcerative colitis. It can be used orally or as an injectable. Oftentimes, and perhaps most often, we're seeing it used in combination. Again, it's been studied well in combination with an anti-TNF medication to help prevent anti-drug antibodies and boost levels. Or methotrexate is good for joint inflammation and sometimes can be added to other biologics or medications that are not as good for treating joint inflammation to give you that additional benefit you might need. But again, needs monitoring every 12 weeks, needs monitoring of the liver tests and blood counts. You should not be giving these patients a whole year supply and letting them disappear without being monitored carefully. Also, methotrexate, you cannot drink a significant amount of alcohol while you're on it, or it will increase those liver tests. So important to counsel patients on methotrexate that do they drink alcohol regularly? If so, that's not a good choice for them. Are they going to become pregnant? If so, in the short term, if so, methotrexate's not the right choice because it needs to be stopped at least 3 months before pregnancy. So monitoring, I've already kind of alluded to this. Before you start azathioprine or 6-MP, you need to check TPMT. That's the enzyme that metabolizes it, and people do vary in how much of that enzyme they have, and that will affect your dosing. You should check the EBV, the Epstein-Barr virus status in young patients to make sure they are previously exposed. Because if you get a new EBV infection while you're on azathioprine, that is a risk factor for lymphoma. And so you want to make sure that they've already been exposed. And most often patients have. It's higher risk if they never have been. And you need to monitor those LFTs and CBC, as I mentioned. Anti-TNF medicines, we know about these for the most part. Infliximab has been out since 1998, so we have a long track record of these medicines. So infliximab is our IV medication, but it now has an injectable form. Adalimumab, certolizumab is for Crohn's only. Golimumab is for ulcerative colitis only. These medications are good when you need a quick induction. In particular, infliximab has been well studied in acute severe ulcerative colitis. So those severe ulcerative colitis patients that are sick enough to be in the hospital can respond on the order of days to an infliximab infusion. And you can also consider it, these medications have additional indications for inflammatory arthritis, for uveitis, and for psoriasis. So for patients that have both, these might be a good option. Monitoring before, you need a CMP, a CBC, hepatitis B testing, TB testing. You should be monitoring liver, a CMP and CBC at least every 6 months, and you should be monitoring that TB test yearly. So biosimilars, there's a lot of biosimilars for anti-TNFs now. So what's a biosimilar? A biosimilar is a medicine made by a different company that is equivalent in safety and efficacy and potency to the originator. So a biologic medicine is called that because a living cell makes it. Only a living cell can create an antibody, and that's what a biologic medication is. And a different company is not going to have the same cell culture system as the originator company. So it's going to be similar to the original drug, but not exactly the same. In fact, the infliximab today is a biosimilar to the infliximab 5 years ago because a biologic product is always going to drift and change. So there have been many biosimilars that are approved for infliximab and adalimumab. Infliximab, you may hear, brand name is Remicade. You may hear names like Renflexis, Inflectra, Epsola. These are all biosimilars. Adalimumab has now 10 biosimilars that have been approved for it. So I tell patients that it's possible that their insurance is going to contract with a biosimilar. I'm not concerned about them switching. Switching from the originator to biosimilar has been well studied and is safe and effective to do. If you have antibodies against the originator, you can't switch to the biosimilar. The antibodies are going to cross-react. So you can't be like, oh, you have antibodies to adalimumab, let me switch you to a biosimilar. Won't work. And likewise, the testing to test for drug levels and antibodies is the same for the biosimilar and the originator. So this is something that's here. I'm trying to tell my patients on anti-TNFs at their visits that this is happening because otherwise they're pretty worried when they get a letter that says your medicine isn't being covered. This one's being covered, and they panic because this is the medicine that made them well. So I do try to bring it up at clinic visits now proactively so the patients know what to expect. It's not anxiety provoking for them. So this is just a list just so you kind of know what they are when you see them. Two of the Humira biosimilars are interchangeable and can be switched without a new prescription, but the other 8 need a new prescription from the provider. There is now injectable infliximab. So infliximab was always the IV only one, but now there's this injectable version. So you still need to do the first 3 doses IV, but then there is an injectable option starting at week 10. So 4 weeks after the last infusion, and then every 2 weeks going forward. And you can see here that, with the IV formulation, you get a spike in the drug level and then it goes down to a lower low. Whereas the injectable never gets to that highest spike that you would get with an infusion, but it remains at a more steady level in the middle. Okay, so that is an option to consider. Vedolizumab, we've had this medication now for 11 years. So it is approved for both ulcerative colitis as well as Crohn's disease. It essentially works by blocking the white blood cells from sticking to the intestinal tract. The alpha-4 beta-7 integrin is specific to the intestinal tract. It is also found in the nose and the back of the pharynx. So the nasopharynx and the intestinal tract are the only place where these receptors that vedolizumab bind to are found. Because of that, the medication is only indicated for Crohn's disease or ulcerative colitis. It comes with a great safety profile because of that. It doesn't increase the risk of infections or cancers. There was this thought about, oh, can it increase the risk of PML? That's because we had a different medication that was a non-selective anti-integrin, natalizumab or Tysabri, that is an MS drug as well as a Crohn's disease drug that crossed the blood-brain barrier, affected receptors there, and did put patients who had been previously exposed to the JC virus at risk for that condition. However, vedolizumab does not cross the blood-brain barrier. It does not affect those receptors in the brain and does not carry that same risk. So it's a very safe medication. However, it's not going to be the medication for that patient with terrible joint inflammation, terrible eye inflammation. It's not going to affect those things. It's going to affect the intestine specifically. Well, here's a little illustration of a white blood cell coming and sticking to the intestine. So we don't have that many head-to-head trials in IBD, but vedolizumab is one of the few that was studied head-to-head with adalimumab. So there was vedolizumab versus adalimumab in patients for moderate to severe ulcerative colitis. This is called the Varsity trial. So it looked at patients on Veto, which are in red, and patients on adalimumab, which were in blue. And you can see that essentially vedolizumab won. It did help overall the primary endpoint of clinical remission and mucosal healing at week 52. It was superior. And then they broke it down by the patients that had previously been on an anti-TNF and those that had not. And the difference bore out the most in the ones that were anti-TNF naive. So of interest. Okay, so new in 2023 and 2024 is injectable vedolizumab. So it's a 30-minute IV infusion. And so now, it's a new start patient, they still need to receive the first 2 doses IV at week 0 and week 2, but then there is an injectable option that they can do every 2 weeks. Or if you've had a patient that's been on Veto for years and they just like the idea of switching to shots because it's better for their lifestyle, they can just switch at any time to the shot every 2 weeks. I think one question is that there are patients on infusions at an interval that's different than every 8 weeks. We all have some patients that are on an every 6-week interval or an every 4-week interval, and we really don't know how to make that translation that well to the shots. So I would really caution switching from IV to shots if they're not on every 8-week dosing, because that's the transition that's been studied. And we really don't have as much information about what's the right injectable dose if they're on a Veto dose that's not every 8 weeks. So just stay tuned for more information on that as we learn more about the injectable. Okay, so interleukin 12 and 23 blockers. So we have had an IL-12 23 blocker called ustekinumab or Stelara for Crohn's and ulcerative colitis for a number of years. In the past few years, we've gotten the IL-23 specific medication. So risankizumab or Skyrizi has been approved for Crohn's and ulcerative colitis. Mirikizumab or Amvo is approved for both, and guselkumab or Tremfya is approved for both. So we have 3 anti-IL-23 medications. So For the IL-12, IL-23, ustekinumab bind the common subunit that is shared between them, the P40 subunit, and then these IL-23 specific medications bind just the particular part of IL-23. So, these are more targeted therapies. So here we go. Okay, so we're going to talk a little bit about head-to-heads that have involved the IL-12/23 mechanism. So we've had a head-to-head of ustekinumab, anti-IL-12/23, versus adalimumab, anti-TNF, for moderate to severe Crohn's. This is called the CView trial. This was a multi-center, randomized, double-blinded, parallel group control trial of biologic naive patients. So recall that biologic naive patients that have never been on a biologic before, this is their first drug, usually do the best. The first drug is usually your best. And so these are bio-naive patients who are failing or intolerant to conventional therapies like mesalamine or azathioprine, and had an ulcer of any size on their baseline ileocolonoscopy. And then patients were randomized 1-to-1, some to get ustekinumab, some to get adalimumab. And what they found is that there was no winner. They both worked well, and actually they both worked better than usual, probably because they were biologic naive patients. But it really tells us there's no one right answer for every single patient. For some patients, adalimumab is going to be the best medicine. For others, ustekinumab is going to be the right medication. And I think we have to take into account these other patient factors in order to try to get at who's who for these medications, but there's not one clear winner. Some of the things that we take into account when we try to make the decision are those extraintestinal things like joint pains or psoriasis, but there's not one answer for everyone when you're trying to choose between these two.
And then
I'm sorry. There'll be time for some questions after, I think, if we want to talk more about it. So risankizumab, talk a little bit about it. It does have this novel injection device. This is called an on-body injector, so it's a little bit different in the others in that this device is given every 8 weeks. So it kind of looks less like a shot. So I have found for some patients that are nervous about home injection or nervous about shots, they feel like maybe this is a little less shot-like. So I find it's helpful to show them a picture or show them a demo so that they kind of know what it looks like and what to expect. So patients on risankizumab get 3 IV infusions at week 0, 4, and 8, and then they get an on-body injection starting at week 12, and then every 8 weeks after that. So the question came about, well, what do we do? Do we keep using ustekinumab? Do we start using these anti-IL-23 medications? So we knew that there was psoriasis data that risankizumab had been shown in psoriasis to be superior. And in the trials for risankizumab, they allowed about 20% of the patients in the trials to have been prior ustekinumab patients. They needed more patients, so they did that. So we had some sense that, like, okay, it's seeming like maybe risankizumab is going to be better than ustekinumab. We have these clues from psoriasis and from the trials, but we didn't know for sure. So they did a trial, luckily called the sequence trial. So the sequence trial is our third head-to-head that we'll go over. It's risankizumab versus ustekinumab for Crohn's disease. And it's a head-to-head open label trial of moderate to severe Crohn's patients that have failed anti-TNF therapy. So these are anti-TNF failures, and the investigators were blinded to clinical efficacy scores, and an endoscopy was centrally read. So to try to mitigate the open label nature, the people that were giving the drug knew which patient was getting ustekinumab, which was getting risankizumab, because they're given differently. But then they tried to make it as objective as possible by having someone, the person that did the scope wasn't the one that analyzed the results. There was a central sort of blinded reader. And so these are the primary and secondary endpoints. Essentially, the bottom line is that risankizumab won. It met superiority over ustekinumab. So clinical remission at week 24, 58.6% of risankizumab versus 39.5% of ustekinumab. Endoscopic remission at week 48, you see 31.8% at risankizumab, 16% at ustekinumab. And there's the secondary endpoints of clinical remission, endoscopic response, steroid-free remission. But essentially, risankizumab did come out superior. Mirikizumab, or Omvo is 3 IV infusions, and then it's 2 shots every 4 weeks. So the patients have to give themselves 2 auto-injector pens at each dosing every 4 weeks. And then guselkumab, or Tremfya is for ulcerative colitis is 3 IV infusions at week 0, 4, and 8. And then you have an option at dosing. You can either do 200 milligrams at week 12 and then every 4 weeks, or you can do 100 milligrams at week 16 and then go every 8 weeks. So it's a shot every 4 weeks or a shot every 8 weeks, depending on what you think the disease severity is. For the more severe refractory patient, I would choose the 200 milligram every 4-week dosing. For Crohn's disease, they're the only anti-IL-23 that has an all injectable option. Only for guselkumab Crohn's is the only all-injectable IL-23 where you can do the 3 loading doses as injections and that or IV infusions, and then you can do the same injection schedule. So this is one of those things that when, we don't have clear superiority data of one anti-IL-23 versus the other at this point. We have 3 available. And some of these things matter about the injectable loading versus IV loading, or the on-body injector versus what the syringe looks like. These are things that when you're talking to patients, I think are important to discuss and come into your shared decision-making about which is most acceptable to them, which do they think they're going to be able to be adherent to. I try to show them demos whenever I'm able to. But I think sometimes that makes the difference in how you're choosing between these in the absence of data showing us that one is clearly better than the other. Of course, if there was data showing us that one was way more effective, we would do that one. Since we don't have that, I think we're at a point where we can be like, well, you need all injectable loading because you're going away to college in the middle of nowhere and can't get to an infusion center, or you are someone that, isn't comfortable with shots yet and wants, the on-body injector that's the least frequent because it's the least shot-like. There's all these sorts of factors that may come into play for patients that really matter to their quality of life and comfort level with the medicine. So monitoring for this class of drugs is a baseline CMP, CBC, hepatitis B, and TB test. And then you should check labs around the end of induction, week 8 to 12, and then every 4 to 6 months after that. Okay, so oral medications, the small molecule inhibitors. There's 2 JAK inhibitors. There's tofacitinib, which is only approved for ulcerative colitis. It has been studied in Crohn's disease in multiple trials and was found not to be effective. Or upadacitinib, which is approved for both ulcerative colitis and Crohn's disease, induction and maintenance. S1P receptor modulators. This includes ozanimod or etrasimod. They're only FDA approved for ulcerative colitis. So JAK inhibitors first, we'll talk a little bit about tofacitinib and upadacitinib. So the Janus kinase enzymes, or the JAKs, are signaling molecules. You can see that they're signaling molecules that are up here near the cell surface, and they signal from many different cytokines. Okay, so there's IL-2, IL-4, IL-7, IL-9, IL-15, IL-6. All of those things are binding to the cell surface receptor, and then the JAK enzymes are sort of carrying the signal down. So they are fairly, I guess, high up in that inflammatory cascade. There are several different JAK enzymes. There's JAK1, 2, and 3, and then there's TYK2, all involved in the same signaling pathway. JAK inhibitors are known for their quick induction. There is day-by-day improvement data for some of these medications. The label in the United States mandates that the patient has either tried and failed or tried and been intolerant to an anti-TNF before they're prescribed a JAK inhibitor. And as we reviewed in the talk before lunch, pregnancy safety for this class of medications is not established. So upadacitinib dosing for Crohn's disease is 45 milligrams a day for 12 weeks for induction. For ulcerative colitis, it's 8 weeks for induction. And then you have the option in maintenance of either doing 30 milligrams a day or 15 milligrams a day. Okay, so this is data for upadacitinib, and this really just speaks to the quickness with which it works. This is day-by-day data for bowel urgency. This came from the patient diaries in the clinical trials, and this was what patients, how they felt their urgency was doing on a day scale. And you can see here, oops, sorry, I used my mouse and it messes it all up. You can see here, day by day, patients were seeing improvement. So that is really quite quick. And then you can see on the left their clinical response at week 2, 4, 6, and 8. This is a composite of rectal bleeding and stool frequency subscores. And again, you can see by week 2, there was a really quite impressive separation between the drug and placebo of 62% of patients seeing improvement in rectal bleeding and stool frequency versus 27% on placebo. So upadacitinib for Crohn's disease, this is induction and maintenance data. You can see that it is highly effective in both patients that have been biologic experienced and biologic naive, that it does meet its endpoints for clinical remission and endoscopic response. So safety and monitoring. So there is a higher risk of shingles with these medications. So it's really important that you discuss that risk with patients and that you make sure that they've gotten their Shingrix vaccine. Shingrix vaccine is safe for patients on immunosuppression. It is not a live vaccine. It is indicated and approved for people 19 and over who are on immunosuppression or who are going to go on immunosuppression. So it should be covered by their insurance, even if they're under 50, because they have this indication that they're going on an immunosuppressant. So you need to talk to patients about it. In our clinic, we give patients the Shingrix vaccine to really make sure that they're getting it. If a patient is 100% sure that they were vaccinated for chickenpox or varicella as children, they've never had chickenpox, you can consider that perhaps they can't get shingles and it's a reactivation of varicella. If there's any question, I would just go ahead and vaccinate them for shingles. This blood clot risk, there is a black box warning on the label of all JAK inhibitors for blood clot risk. This came because in the oral surveillance study of tofacitinib in RA patients who are over 50 and also had cardiovascular disease, there was a higher risk of blood clots seen in those over the age of 65. This data was in tofacitinib in RA, but it has been extrapolated to all drugs in the class, though it has not been studied in IBD patients or with upadacitinib, but it does carry that warning. And I think it is important to talk with your patients about the warning, where it comes from, and if they have a personal history of blood clots, a genetic predisposition to blood clots as well, because you may want to think about a different medication if possible in that case. These agents do increase cholesterol, so it's important to check a baseline cholesterol panel and monitor it at the end of induction and then periodically through therapy to see if that's something that's going to require a dose reduction of the medication or is going to require additional treatment of the cholesterol. So that's important to keep track of. And then acne or JACNE, as some have called it. It happens with upadacitinib. It seems to happen most at the beginning at the higher dose and seems to get better with time and dose reduction. So it's something I warn patients about. I tell them we expect it. I tell them we can help them through it. Oftentimes we've prescribed clindamycin 1% lotion, and that's been really helpful for them. So I have had a handful, less than 5, I would say actually, of patients that I've had to dose reduce their upadacitinib because it was intolerable to them and didn't get better as they went into maintenance. But for the most part, patients are like, you know what, I feel if they feel good on the drug, they're willing to do what they have to do to manage it. But something to warn them about nonetheless. Lab monitoring, as I mentioned, CMP, CBC, shingles vaccine, lipid panel, and follow those things. S1P receptor modulators, this is ozanimod or Zeposia, etrasimod or Velsipity. These are only indicated for ulcerative colitis, not Crohn's disease. They're all also oral once daily pills. They essentially work by blocking white blood cells from leaving the lymph nodes and getting to the intestinal tract to cause inflammation. They are used in multiple sclerosis as well. And they're, as I said, only approved for ulcerative colitis. This is some data about etrasimod efficacy. You can see the clinical remission in their studies at week 12 of induction. You can see that clinical remission was 19.8% higher in patients on drug. Week 52, it went up to about 25%. So things to know about risk factors for S1P receptor modulators. So there is this first dose heart rate reduction. The receptor for this drug is found in the heart, so it can lower the heart rate. Macular edema, that risk is greater for patients with diabetes and uveitis. So you do need to make sure they have an eye exam before they start. It's also higher risk in patients with a reduced FEV1, DLCO, and rarely pulmonary fibrosis. Um, Liver enzyme elevations have been noted in MS. Those have normalized with follow-up. And then there is a higher risk of herpes zoster and herpes simplex. So again, shingles vaccination is important to discuss and make sure that patients are getting. You cannot use it if a patient has had a recent heart attack, stroke, or if they have any history of heart block. You have to do a baseline ECG to make sure that they don't have any heart rhythm abnormalities. Patients that have had uveitis or macular edema must have an eye exam first. All patients should have an eye exam around the time of starting, but it's really essential that it's before starting for those that are the highest risk, the ones with history of uveitis or macular edema. Should make sure they're vaccinated for shingles and then monitor the LFTs and CBC through therapy. Okay, so in summary, moderate to severe ulcerative colitis therapy includes anti-TNF medications, anti-integrins, anti-IL-12/23s, JAK inhibitors, or S1P receptor modulators. Moderate to severe Crohn's disease includes anti-TNF therapies, anti-IL-12/23 therapies, anti-integrin, and a JAK inhibitor, upadacitinib. Just briefly about pediatric therapy, steroids, mesalamine, and immunomodulators are used. Unfortunately, the only FDA-approved biologic options are infliximab or adalimumab. However, there has been off-label use of vedolizumab, ustekinumab, risankizumab, tofacitinib, and upadacitinib in the literature, and there is data for those medications if they're needed, though often it'll require a peer-to-peer and some discussion with the insurance to get it approved. So treat to target an inflammatory bowel disease. This really means that you choose a treatment, you choose what your target's going to be, and then you check it, right? You say, okay, we're going to choose this therapy and we want to target mucosal healing. We're going to do a scope. We're going to see if we got there. If not, we're going to check your drug level. We're going to adjust it. We're going to check again. And that's your treat to target. And you do it stepwise, right? Our first goal is to be getting a symptomatic response. And then after symptomatic remission and normalization of the CRP, you want to make sure the calprotectin is normalized. And then, of course, you want to make sure everything has healed. So it's really, and I set these goals with the patient because a lot of times they're like, well, how am I going to know if this is working? And so I set that up as this is the expectation, and we're going to do these things at our future visits to check on it. There have been studies that show that when we modify our therapy to specific targets, patients do better. And how do we monitor? We look at objective markers like weight loss and fever, serum markers, imaging, CT, MRI, or intestinal ultrasound, and endoscopy. So then to finish up, induction and maintenance therapies are chosen on multiple factors, including other immune conditions, extraintestinal manifestations, in addition to the bowel disease. Treat to target is established and is a good way to make sure you're reaching your goals. And patients should have individual proactive disease monitoring plans. Your job isn't done when they're well because you really need to make sure that you keep them well. And with that, I will end and answer any questions.